Good. Welcome to Lumbars. Today, this lumbar spine, what we're going to talk about is something that everybody hears about. We're going to talk about the crazy legendary stuff and how spines don't wear out and how discs can regenerate. What I want you to understand is that this spine is renewable. So nobody has discs more than 14 months old. And it has certain design features to it that allow it to be flexible and strong. In between each one of these bones is ligaments, multiple ligaments. And in fact, if you could appreciate the strength of this, when I was teaching human dissection, you can take a probe that looks just like it looks pretty much similar to a pen. You can pass it through bone with very little effort. You can't beat it in a disc with a hammer. Now the disc is super, super strong. So when somebody says, oh, it's a bulging disc, slip disc, herniated disc, that doesn't make sense because it can't happen in an isolated environment. So you've got this incredibly strong and flexible body. But I also want you to understand, and we're going to concentrate on just the lumbar area, why do you think it's shaped like a curve? Say because it's a spring. It's a spring. That's so true. Because when you bounce, I mean, you figure if you cut my torso off from here up this much, you're probably talking over 100 pounds of human spread over the size of about a 50-cent piece. And so if you get this type of force loading on it, it's going to deteriorate unless it's a spring so it has that cushion. Now the way the body is laid out, all the weight of the body is on the disc. And if you look at this is the front part. The nerve comes out the back half of it. So the weight is positioned towards the front, the nerve comes out the back. And I want you to appreciate that because when the disc bulges and this herniates, it puts pressure on that nerve. And you're going to see how postural distortions, you know how people are bent over like this? That's a clue that there's pathology in the disc. Okay, it's not, sit up straight, you're slouching. It's why do you find slouching comfortable? So appreciate that this disc is incredibly strong. And in fact, I was at a conference this past weekend in Las Vegas, and one of the doctors said, yeah, my L4, it's herniated. Is that possible, Doc? No. It's not possible to have one disc out. That's foolish. Okay, in fact, when you look at this, but that's what he was taught. That's what he was told by the MRI that he was laying down. And it's impossible because you can't have just one problem. Could you just have a problem with high blood pressure? No, it's impossible. That's a physiologic reaction. Okay, so the blood pressure problem is going to be a factor of heart rate, of health of the blood, of stress levels, physical, chemical, emotional. Same thing with this. Now that disc is 80 interconnecting rings of ligament going around it, surrounding this like spongy center called the nucleus pulposus. And so imagine Kevlar, with 5 or 6 layers, imagine 80 of them. So it's so strong and it's designed to last forever. Now, when you're looking at the nutrients of this, you've got so much forces coming down on that the disc has a poor blood supply. It gets most of its nutrients through movement, and that's called imbibition. So that allows nutrients to get into the disc. So what causes disc degeneration is abnormal force loading, okay, or lack of movement. So when you see a disc herniation and disc bulge herniation, they're all the same thing. What you're looking at that's different is a disc sequestration. And that's where a piece of that center called the nucleus pulposus is broken free and it's inside of the canal. Now I've seen every one of these sequestrations, bulges, herniations get repaired. Okay, not surgically, but by the body itself. So I want you to have an appreciation that no matter what the disc problem is, as long as there's movement, you can regenerate the disc. Now, if I had $1 for everyone that said, I got that sciatic nerve, and I want to say, so do I. Mine feels good. Everybody's got a sciatic nerve. It's not a disease, okay? The sciatic nerve, it comes out of the back, okay? It's got 5 nerve root origins, the back and the top of the sacrum. But where it goes, where it supplies, that's where you feel. You don't really feel where it comes right off of the spine. And this nerve, it's huge. It goes right down the back. But when you look at this, and this is a dermatome map, and the dermatome is an area of skin supplied by a specific nerve root. I had a patient, and 2 years, and this is like, you know, do you have any of those fears, like sticking a needle in your eye or something like that? This is one of my fears. He had groin pain, and for 3 years they were shooting him in the groin with a needle to stop it. Okay, and he comes in and he says, you know, I got this pain that comes right here. I know where that is. That's the thoracolumbar junction. I can fix that. Let's take an x-ray of you. And it came on after he was snowboarding, and you're going to see why that's so important, with the torso going one way and the lumbar going the other. It took us just less than a week to take care of his groin pain, but it's always here. Now, the further away that you feel the site of injury or the pain, that's the more the nerve is crushed. And so what happens is when you're healing from a crushed sciatic nerve, at first you might feel back pain. Then you might feel the back pain goes away, but the butt hurts worse. Then the butt pain might go away, then the back of the leg hurts worse. And the back of the leg pain goes away, it's just the calf. That's the worst thing you can have, because the site of symptoms is further away than the site of the lesion. So during therapy, when we're regenerating that disc, the calf pain goes away, then the back of the leg hurts. Then the back of the leg goes away, then the butt hurts. Then the butt goes away, then the back hurts. And people are saying, what's the deal, doc? And I say, that's centralization of symptoms. You know, now that it's up at the disc level, we can knock it out. Okay, so when we look at this, this is what the front part of the spine looks like, because you've got muscles that attach up here. I know the muscle is called the psoas. I know you would think the psoas is here. No, the psoas, it's up here. It's in the front, okay? And what happens, it comes down, and it's one of the muscles that lifts the leg, okay? Except if you're sitting all the time, that muscle is going to be chronically short. So people that chronically sit, they're going to have an increased tone of that psoas. And there's a lot of people that work on those muscles, and they'll say, yeah, it's tight, it's tight, it's tight. However, muscles don't just tighten up. There's got to be a reason for it being tight. And when you look at the origins of the sciatic nerve, it comes out of the base of the lumbar, and it goes down, and also the top of the sacrum. So this whole area here is where that sacral nerve comes from. Now the sacral nerve, it's about the diameter of your index finger, and it's about this long, okay, and it's so strong. If you could feel it, it feels just like a telephone cord. So imagine a flexible, strong telephone cord that's this diameter, and you could literally pick up an entire cadaver with it. It's that strong. So it's not something that tears. So typically a nerve is going to get injured right at the site of where the disc is, where it's most vulnerable. Now, see how the sciatic nerve comes out here and goes down the leg? Well, that's important because there's a lot of muscles around it. Now, if you remember, there's name the muscle that goes across the posterior aspect of this joint.
There is none.
What, doctor?
There is none.
There is none. Yeah, baby, he would pass my final. Okay. Yeah, there isn't a muscle here. So this is a perfect joint, the SI joint. So why would an SI joint start to malfunction? There's a muscle that crosses the front portion of it called the piriformis. Now this muscle turns the hip in and out, but you got to figure if this joint is unstable, and this is a perfect joint, we cover this in the pelvic health lecture. So if there's long-term low back issues, the area above and below got to move twice as much. If it moves twice as much, it begins to wear out. So if it begins to wear out, the only muscle that crosses it is going to increase in tone. So when somebody says they have a piriformis syndrome, that muscle is chronically tight. Now, it's curious that the design feature of this, the piriformis goes right on top of the sciatic nerve. So a lot of piriformis, if that muscle's tight, it's going to compress that nerve and it's going to go down. And a lot of people actually do surgeries. Sometimes, rarely, the sciatic nerve can go through the piriformis. But they'll operate on the piriformis, and that doesn't make sense. Can you imagine being 40, 45 years old and someone says that you have a chronic piriformis? So you've made it through nearly half a century with no pain and somebody just is identifying a problem? Can you see the dysfunction there? That doesn't make sense. Okay, so what I want you to start doing is asking why. Why is that piriformis chronically tight? Why is the sacrum or the pelvis now starting to give me symptoms? And it all happens to do with the instability of the pelvis. So all of those muscles in there, if the muscles are tight, it means the pelvis is unstable. If the pelvis is unstable, it means that there's a chronic low back issue. So we never repair the pelvis. We always got to look for the problem. Now, this is huge. Can anyone say horse's tail in Latin? Cata equina, yes, yes. Equina? Tomato? Tomato, okay. Cata equina means horse's tail. Now, this is one of the most important aspects that you can imagine. The spinal cord stops up here at the top of the lumbar. It continues on as a bundle of nerves. Now, the cord itself is a long tubular brain. And the end of it, it's a little cone in the middle called conus medullaris. I know, I just said cone in the middle in Latin. Okay, and the horse's tail comes right off of that. So this is important when you look at it, and this is an actual body in situ, and you could actually check it out on the spinal, the actual human dissection we have over there. But this is the nerve pathway that comes off of it. And you'll see it start way up there at the top of the lumbar. Now think of this, and this is something that I really want you to own. You've got the rib cage up here, which makes the thoracic area not real mobile and flexible. And you've got incredibly mobile and strong lumbar, so you've got a junction here that's sensitive to damage or trauma. So if the body's going one way and the torso's going the other, it can damage that area. It's called a transitional area. Okay, does that make sense so far? Now, so in sports that cause the torso to go to one way and the pelvis to go the other way, that can damage that sensitive area. Now, this is super important because this is often missed. I mean, like 99% of the time. In injuries, sports injuries like this, guess what happens if you damage the cauda equina or put pressure on that area? You're talking not just back pain, sexual dysfunction, gastrointestinal disturbances. And if you're disturbing the nerves that supply that area, bladder and bowel dysfunction. Bowel dysfunction. Let me see. Isn't serotonin produced in the gut? So you're talking altered gut function. We're talking all of that can happen. And it's missed because of some old sports injury that occurred at that joint. So this is super important that you understand. Cauda equina syndrome, typically if it happens immediately, it's almost like an emergency surgery. But you can separate and take the pressure off of it, you can save a life. However, even minor injuries can present. We just had a patient who's 24 years old with sexual dysfunction. That doesn't make any sense. Guess what he did? Skateboarding, BMX riding, snowboarding. Okay, super healthy young guy. And of course, Mountain Dew, Slurpees, fast food. So, he's got some issues. Now, when we're looking at the lumbar, remember, a disc can never malfunction. It's impossible. It's designed for 120 years. However, if a disc that has abnormal force loading, does that make sense? It's going to start to not function correctly. So when you look at the basic design of the human, the head should be over the bottom. We have these curves there for the coiled spring aspect. I know, I'm excited too. So you have this coiled spring aspect, okay, that can take up the shock absorbing. However, when you have a trauma what throws the head forward, remember where I told you the nerves come out? The nerves come out the back half. So here's the scenario. Bam, you get a little bit of a trauma. That tightens up all or compresses the nerves, that tightens up the muscles that you don't have conscious control over. Now, if you have tight muscles, does that increase the range of motion or decrease it? It decreases. So what that does, knowing that these discs get their nutrients through movement, you decrease the movement through there. That decreases the nutrients flowing in the disc. And that causes the disc to start to get compressed. So what does the body do? Knowing that the nerve comes out the back, what the body's going to do, it's going to start to round over those shoulders to open up the discs. So when you look at this person here or here or here, they've had some kind of trauma that's altering the disc function here, and that disc function, not dysfunction, the disc function, there's a tongue twister for English, okay, is causing the body to distort its natural form. Now, here's the problem. If the head weighs around 12 to 15 pounds, you put that head forward about 5 to 6 inches, what's the body going to do? You're not going to walk around like this. So you're going to start to round over the shoulders in order to flatten out the curve in the back to start to adapt. So, and I want you to own this, that a disc can never malfunction. So when the doctor comes up to me and says, yeah, I got an L4 disc problem, I say, no, you don't. So what did I first check on him? I checked his calf. Was his calf functioning good or poorly? Poorly. Then I went in and I approximated his hips. What do you think he felt? Relief, yeah. So he's got an SI joint dysfunction. He's got abnormal leg function. Wouldn't you love to see his x-rays? I mean, just neat stuff, because he's going to have forward head carriage or this. So it requires a little bit more detective work than just dissecting things. This is the psoas muscle, and muscles 99% of the time are never a problem, but they can be increased in tone, and the reason they're tight is the problem. So too many people are working on the muscles and they're not finding out why. If this person is sitting all the time, can you see how that muscle comes off of the back into the front of the legs? And if you're sitting, that muscle is going to be chronically tight? So you've got to find out a way. So, some people have to sit during the day, but there's certain exercises that you can do to keep those discs hydrated in order to allow the body to get corrected. Now, and this is a normal spine here. If the disc space gets smaller, you're going to get it rounding over to open up those holes where the nerves are. Does that make sense? And so when you look at a teenager who slouches all the time, it's never sit up straight, you're slouching. It's why does he find slouching comfortable? There's got to be some kind of forward head carriage. We just got a kid in, 13 years old, with chronic ankle and foot problems for 2 years. Do you think it's an ankle or foot problem, or do you think the nerves in the back are compromised? I mean, come on. This is like 13-year-old kids don't have foot problems. Okay, so sure enough, he had beginning bunion formation. His foot was flattening out, and guess what he says? It runs in my family. What do I say? No, flat feet don't run. So when you look at it, sure enough, he had no curve in the neck, forward head carriage, causing a loss of curve here. Now, so what do I ask his dad without the neck curve? Did he have ear infections as a kid? Yeah, he was born C-section with a cord wrapped around his neck. So then you can start to connect the dots, but the doctors today don't. They don't. They just think a foot problem is a foot problem, instead of the foot pain or dysfunction as a clue to other aspects of it. So this here is looking at the side view of a lumbar. This direction, you're going to see a normal disc, okay, about halfway up, and you can't even see the disc, okay, on this left one. A year later, 2 years later. Now, symptoms went away after 6 weeks. Here's the problem, okay, and this is why a lot of I don't want to say Obamacare is immoral, but this is why a lot of insurances are immoral. This right here, his symptoms went away after 6 weeks, but do you think we were able to regenerate his discs after 6 weeks? No, you're talking between 6 and 14 months, depending on the amount of damage. So if his insurance covered 20 visits a year, what do we do? Spread him out? Keep him sick year after year? Then give him drugs? No, that's immoral. No. So a year later, you can see the disc spaces are about double. 2 years later, it's fully regrown. And then he's healthy. But what's more important, though, what do those nerves supply? His prostate, his bowel, his bladder, his immune system. I mean, this is everything. So the doctors that are watching this have to rethink their protocols. The patients that are looking at this have to respect the body that it's got symptoms for a reason. Okay, now, MRIs. When you're looking at a body, okay, like this, gravity is pulling down this direction. If you're laying down, which way is gravity pulling? This direction. Okay, so a different direction. So what they found out is that if you're standing like this, you're going to have a different picture. If you're standing like this or laying down, a different picture. So when patients come in with an MRI, I say, was it done weight bearing or laying down? What do they say? Laying down, because this is the most popular one. This is what most doctors have invested in. This one only biomechanically correct doctors will use. This one will show different pathologies like fractures, tumors, soft tissue lesions, bone lesions. This one will show disc bulges, herniations. Now here's a report out of the Clinical Radiology Journal out of London. It says MRIs routinely used to assess back pain with radiculopathy. Radiculopathy is called radiating. It's like out of a spoke. So pain here is pain here. Pain that radiates down is radiculopathy. However, the image findings often correlate poorly with clinical findings. See, when they first came out with MRIs, they decided to MRI a bunch of people with back pain. Makes sense, right? A few $1,000,000 for a machine. And they found out that like over 90% of the people they MRI'd had a positive disc bulge, had back pain. Then somebody said, hey, I got an idea. Let's MRI people that don't have back pain. Oh! Okay, because when they did, they found out over 80% of them had a positive disc bulge, even though they didn't have pain. I know. Bummer for science. I mean, bummer for profit. Okay, a winner for science. And this is the difference. This is an MRI of somebody laying down, and you'll see the spinal cord there. And here is an MRI of someone standing up. So you can see the force loading is radically different there. Radically different. But even this, it doesn't show the real reason. Because you can see, obviously, that yellow circle area, there's something wrong with that disc. The question's got to be asked, why is that disc malfunctioning? Does that make sense? It's not an isolated environment. Is that connected to the lumbar and the thoracic and the cervical spine? Could there be a lateral deviation or forward? Yeah, none of these questions are answered by an MRI. Now, this is a patient who has had 7 back surgeries. I know, 8 would make him better. Okay, no. He decided that perhaps, because what you're looking at this is him standing up straight in the middle. Now, this is a fake disc, 6 bolts. They removed part of the bone. And I know this is a shocker. He's still hurt. Okay? So what we do is we take that spine and bend it off to one side, take a picture, bend it off to the other, and take a picture. And what you can see is there's an arc on this right one. It's flat on this left one. But if you look at the top of the lumbar, at the top of the picture, it looks like he's bending about the same distance. Okay, does that make sense? So he's bending just as far either side, but the mechanics of the lumbar are completely altered. This is why when you look at this, a dynamic weight-bearing stress x-ray, that just means we're seeing how the body works inside, and bend it and see where the dysfunction is. And sure enough, he's got 2 areas there where the discs aren't working correctly. See, when you bend the spine, and this is going to sound ridiculously simple, it bends the way you would think. It opens like a book, where the disc should be narrow on the concave portion, wide on the convex. You bend it the other side, guess what? It should bend the same way. Okay, where it should be narrow and wide. However, when you're looking at this one bending, we're seeing the discs that I have outlined are actually wide on the concave portion. There's 2 of them that are dysfunctioning there. So it turns out his pain is above the surgery site. How did they decide to do the 6 bolts and the fake disc and everything? What definitive test did they use? A supine MRI. So they were looking in the wrong place. Yeah, they're working in the wrong place. Now, if you look at this, and I just did a conference in Vegas, so this made sense to me. I don't know if you know about Vegas, but they have a bunch of places there called gambling. And they work with numbers and odds to actually attract people. Great, okay? Luckily, you don't lose too much money, you're okay. So if you ask a surgeon what's the success rate of a back surgery, they'll say 98%. And they're right. Okay? Because what they're looking at is they knocked the person out, they woke them up, and the fusion held 98% of the time. Now, if you're talking symptoms, that's totally different. Okay, you want to talk about symptoms. It's going to be a little different because if you had one level fuse, depending on the study that you're looking at, it could be between, 40 to 80% success rate. Now, if you read that backwards, that means it failed between 20 and 60%. But now, how long? How long of a study is it? Okay, do they follow them for like 1 year, 5 years, 10 years? So you got to look a little bit more into that. If you're talking about pain reduction, if there's 3 levels, the success rate drops down to 15%. That's, anyone good at math? 85% failure rate? Okay, so if you go to a mechanic and he fails 85% of the time, not a good mechanic. Okay, so when you look at this, you've got to look at the statistics, but long term. When they're talking about microdiscectomy, and I love this, it sounds so little and small. Okay, where they actually have to go through your body, into your body, with little tiny instruments and cut out a small portion of the disc without removing massive parts of the bone. Okay, it sounds nice and neat and easy. And what they did is they found out that surgeons, again, say it's about 95 to 98% success rate. What are they measuring? They're not measuring pain. They were able to knock the person out, go in there, remove stuff, get out of there, wake the person up, bam, success. But when you talk about pain relief, 74% was the overall sex rate if they return to pain without medications, or return to work without medications. However, it's work comp, it was only 29% effective. So you start looking at this and you say, wait a second, that doesn't make any sense. How can, how can the surgeons actually look at this and how long are the studies? And so when you look at any type of surgery, you're going to alter the mechanics of where you're operating on. Is that going to affect the area above and below the surgery? Yes or yes? Yeah. Yeah, so here's another study, and this is interesting. This is about X-stops. And X-stops, one of our patients was one of the first X-stop recipients. So there wasn't a lot of data on him, so he was involved in the study. It's a little piece of metal that goes in between these spinous processes here to force this open. Now that's going to open up, hopefully, the hole where the nerve comes out, called the IVF, or intervertebral foramen. And so it's a little piece of metal in there, or they just do a little incision on the side or on the top. They don't need to open up the muscles or anything else. Mechanically, it sounds okay, except you got a piece of metal in the spine that's altering the mechanics. I'm being really sarcastic there. It's okay, except you have a piece of metal that's totally altering the biomechanics of the spine. Well, here's one, and this is out of the European Journal of Spine. High failure rate of interspinous distraction devices, X-stop, for the treatment of lumbar spinal stenosis caused by degenerative spondylolisthesis. High failure rate. Now, this is out of their study. When you look at the numbers, and I'm sorry about all the words in here, but you look at it and your eyeballs glaze over after a minute. First, you could stop here. 8 out of 12 patients recorded significant improvement in pain, claudication, radiculopathy. Great. 8 out of 12. So that means 4 out of 12 didn't do well. Anyone good at math? 4 out of 12? 30%, right? Okay, good. Just checking. I just came from Vegas. I want to be sure that I'm dealing with the shysters. I mean, the number shufflers. Okay. So 30% success rate here. But then we read it on. If you follow them for 12 weeks, okay, it's totally different. 2 of the patients that had pain relief had a recurrence of it. So now instead of 4, we're up to 6. Okay, good. So that would be a 50% success rate. Don't stop here yet, because that's only 12 weeks. Okay, at 24 months, okay, a third patient experienced a recurrence. Okay, so now we're talking 7 out of 12 had a negative response. And it's just doesn't make any sense. Here's the patient that was experimented on. Now, he was 83 years old when this was taken. This is the metal device called the X-stop. Do you see where the problem is? A blind man could see it. It's above that site. except I'm telling him that it's going to take about 6 months to get him out of pain. It's going to take about, actually to reshape the spine. It'll be about 5 to 6 weeks of adjustments in order to get his body pain-free. He said, no, doc, they said I'd be in and out in a day, I'd be walking the next day, and I'd be permanently fixed. Okay. Yeah, it didn't work. Okay, and this is the actual metal device. When you look at this, and this, it might be hard to see, but this is looking at the side view of the lumbar. Now, do you see how this bone is connected to this bone, connected to this bone, connected to that bone? Okay. Now, it might be hard in the back row, but I want you to take a look. This square bone is lining up with this square bone, lining up with this square. This bone is shoved backwards. Can you see that? That's called a retrolisthesis, or of the lower one, an anterior listhesis. It means, litho means stone, so it means it slid forward. Now, they're not going to fix this because only a chiropractor can fix this. Okay, so this is a medical study. So I'm looking at this and I'm going, there's the problem. The bone slid. It's an anterior listhesis. You need to get this and adjust that and stabilize the pelvis and regenerate the disc. But no, here it is. It's still anterior listhesis. They're just trying to open this area up. And this is even off of a study showing the X-stop and showing it done. And it's I can see this. Anyone can. They're not fixing it. Oh. Okay, epidurals. Dural covering, dura mater covers the spinal cord. Dura means tough, mater means mother. So you got this tough mother covering, honest to goodness, don't you love that? You know the Greek guys were just cool. But it covers from the spine all the way down. So the idea is that you get a needle in there, you go above the dura mater, you don't go too deep, because if you do, you're going to hit the spinal cord, and you squirt this in there that's going to cause a shrinkage, okay, because you're injecting a steroid, and that's going to shrink the tissue and alleviate some of the pain. However, the steroid injections actually damage the tissue, so it's temporary relief at best, but it's damaging. And when you look at this, hospital-acquired infections. See, this is only temporary. Is it going to regenerate the disc? No. And since they're limited to usually 3 or 4 shots, because if they do more than that, it's going to totally destroy the tissue. It can damage the ligaments, it can damage the bone, it can cause osteoporosis. But also, hospital infections cause as many deaths as AIDS, breast cancer, and auto accidents combined. Okay, and you look at this, over 100,000 people a year die. 1 in 20 have a hospital-acquired infection. So a hospital is a very dangerous procedure. And I'm going to show you a patient here in a minute who's got, well, this patient here, perfect. I could use her as pictures of perfect knees. She's 47 years old. These are knees of a teenager. There's absolutely perfect. What does her lumbar spine look like? Okay, can you see that? Now the third lumbar supplies the knee. So she comes in and the doctor was saying, yes, you have knee pain. Let's give you a non-steroidal anti-inflammatory, Advil, I believe, Motrin. Nobody was going to fix this upper lumbar. But if you look even closer, that right there is an impacted fecal area. That means that her nerves to her digestive tract are just shut down. So she's starting to toxify. She doesn't have good peristalsis. The knee pain is just the light on the dashboard telling her that there's a problem. Those nerves that come out of the low back, that cauda equina, they're compromised. Her body is unhealthy, and all it's presenting with is knee problems. Did anyone, when she presented with knee problems, respect her body and take a picture of the whole spine? No, not, and this is how healthcare's got to be. We got to take a stand and say, no, find out why my body's giving me this intelligent response. And it just makes more sense. Now, back surgeries are going incredibly high. This was a study out of Florida, and it's interesting. They have questionable necessity. You went from 969 surgeries in 1992, 20 years later, 16,000 surgeries. Now, when you look at the hospital records, you can find out if they have massive radiating pain going down their leg, they're losing bowel and bladder function, hey, maybe surgery. But if you have pain for a few weeks, you should try some conservative care. Does that make sense? Okay, so they found 66% of the surgeries were probably not necessary. Okay, and you can imagine that, because if we had 1,000 20 years ago and now there's 16,000 surgeries, does that seem like a rash of epidemic of back pain? Yeah, or is it a rash of surgeries? And of course the costs have also gone up exponentially. Yeah, so it's a profit motive. Now, this, I'm not a fan of axial traction. What that means is just pulling the spine apart. And that's what these automatic machines are doing. They're separating the bones. Can a disc herniate if you have perfect biomechanics? No, it's impossible. This biomechanics, where you got the curve here, the head lined up, this direction, it's going to last 120 years. It will wear out if you have altered mechanics like this. So if you have an altered mechanic like this, you have to put a force load here and a force load here and a traction load here in order to realign that spine. Does that make sense? If you just put this, grab this person here and pull, you're not going to affect it by putting a force load in that direction. Does that make sense? No. That's why when I design this table, we distract it and put a force in that direction. Okay, so the disc decompression I'm not happy with. These don't work. That one on the right is beautiful. It's using gravity. I used to have one, but we can't use these anymore in this country. If you're eating the standard American diet, your blood is toxic and your arteries are weak. Okay, if you're like the standard American, you're taking Advil, Motrin, Aleve, a couple of blood pressure pills, an antidepressant, a few antacids, sleep medication, so your blood is extremely toxic. So if you put your feet above your head like that, you're going to massively increase the blood pressure in your head, and this is toxic with weak blood vessels. Okay, so it's just poisonous. And a standard American cannot use this. A regular human, this would be beneficial. Okay, but in America, you can't utilize it. I had one in my clinic, this is years ago, and I had a guy that goes up and he goes, "Wow, doc, I feel dizzy," and his eyeballs are flipping in. And I said, "Wait a second, you told me that you didn't take any medications whatsoever." "No, I don't, doc, I'm really healthy. I do take the aspirin a day for a healthy heart." And I'm going, "Okay, great, you're taking the leading cause of kidney disease, a blood thinner that weakens blood vessels, okay, and we just increase the pressure in your brain." No. This is ridiculous. You can't do this. You can't do this in this country. This gal, 7 surgeries. This is the site that they worked on. Can you see where the problem is? That's her post x-ray. We don't work on the surgery site. I don't use a wrench. Okay? Or a screwdriver, I don't know. Okay? You work above the site and you repair it. Then we stabilized her pelvis and she got better. This one here is the worst exercise ever if you have a disc injury. Remember, weight bearing, the nerve is in the back. The disc spaces are shaped narrow at the back, wide at the front. If you lay on your back, what happens to the pelvis? It flattens out, the lumbar flattens out, but also too, the holes where the nerves come out open up. So this feels phenomenally good. In this position here, that back is opening up and it feels great because you're opening up the holes on the nerves. However, you're reversing the discs. So if you stay like that for a half hour and go to stand up, has anyone done that? Oh, it's miserable. What's worse is this has been described by physical therapists to lay on your back and you lift your legs and stretch it. Oh, you're going to stretch the back muscles. You don't want to stretch the back muscles. You want to increase the curve in the back. Does that make more sense? Because if you stretch the front, you're creating a negative pressure and that moves that disc material to the front. That makes a heck of a lot more sense. Biomechanically, this is just crazy. Crazy.
How about a slant board?
After. Slant board, we just covered. Okay, don't do it. Not in this country. Now this here, these little tiny devices, like a foam piece, they increase the curve of your back. So this is going to help with sitting. But what you want to do is keep it back there for no more than 20 minutes and take it out for 10 minutes. 20 minutes in, 10 minutes out. That's because it takes 20 minutes under human tissue. I'm going to describe plastic elastic deformation. If you take any material and you put it under a force load and then let it go. And that's an elastic deformation. It returns to its original shape. Does that make sense? If you put any material under a given force load for a given period of time, it can retain the new shape. And that's called a plastic elastic deformation curve, the amount of time and pressure applied. And this applies with wood, steel, human beings, everything. At 18 minutes of consistent pressure, human tissue maintains that pressure. So what do you want to do? When you're sitting, you're flattening out the disc, you're causing a dysfunction back here, so you want to put that pressure at the top of the lumbar for how long? 18 minutes, and then take it out. So the whole time you're sitting or flying or driving or working at the office, you're getting that lumbar curve coming back and you're restoring the nutrients and motion to it. Now, this is phenomenal. This is better than a slant board. This is better than an inversion device. In America, it's safer. Is movement. And I'll get people that are so scared, and I call this the scariest exercise you're ever going to have. Why? Because then the back goes out, they move, and they just about die, right? Okay. So what do I tell them? I said, what we want to do is induce movement. Put your hands like this, feet wide apart, and then I want you to turn. I want you to turn as far as you can, but I want you to use these as momentum. And you know what I show them to do? This, where they're looking behind themselves. I know. They go, oh! You want me to do that? Yes, okay. But you can't do that on the first day in acute pain, but after a week or so of adjusting, depending on the case, once you get them to be able to do that type of movement, it's phenomenally good for the body.
While you're on the slant board?
This right here, this right here, we're going to answer questions later, hon. This right here is the trochanter support, and this stabilizes the pelvis. But remember, the pelvis is never the problem. It's a clue to long-term low back problems. Does that make sense? Plus, too, if you're sitting on this bone, it opens up the pelvis. So the pelvis, a lot of people have said, yeah, my back hurts, and I'll go in and approximate the hips, and the pain goes away. But that's just a parlor trick. It takes about 3 to 4 weeks to stabilize the pelvis with the trochanter support. It's fantastic. Did you know the side effect of muscle relaxants is muscle spasms? Did you know the side effect of antidepressants is depression and suicide? Did you know the side effect of pain relievers is pain? I know. It's odd to think that we would be, because these cause a hypersensitization of symptoms. So on your sheet, you're going to have some stuff in there that actually is for a real pain relief. But this is dangerous and toxic, and there's a lot of safer alternatives. I mean, when we look at this, Tylenol and nonsteroidal anti-inflammatories destroy the joint cartilage, proteoglycan production. That means every time you take it, this ligament that we've been talking about so much, this disc, starts to become destroyed. The cartilage in the joint on the back becomes destroyed if you take a pain reliever that's a chemical. So this is why a lot of doctors and healthcare professionals say, once you got arthritis, you can't reverse it. No kidding, you're treating it with a chemical that causes it to guaranteed to progress. This stuff here is actually anti-inflammatories and pain relievers that work. Why? Because they give your body the materials to regenerate the tissue. You give healthy nutrients and movement, and it works. This drives me crazy. This patient here, okay, now that's them standing up straight. They came in with fear because they had a disc dysfunction. They had MRI, okay, in the wrong position. It showed a disc bulge. We go in and take a weight-bearing x-ray. Can you see that this is bent off to the side? Can you see that the rib cage area is also torqued off to the side? So that means that she had an injury here, forward head carriage, and it's compressing on the nerves that supply the bowel, gastrointestinal area. So all of these, the depression, the fibromyalgia, and she's only 44. And she came in originally just to get her back fixed because she didn't know that we could help with the bowel dysfunction of the fibromyalgia. Because there's nobody else that appreciates that all those symptoms are intelligent responses by the body. They're not pathology. They're the body saying, look, I got this red flash of light. I need to get it corrected. Does that make sense? So discs can regenerate. The body gives everything, all symptoms for a reason. What you require to have healthy discs is you have to get the system checked for nerve pressure. That means if you have back pain, should you check the entire spine? Yes or yes? Yes, good. Yeah, my work is done here. And then when you look at this, exercise, that's just movement to get fluid in there. Proper nutrition, it just means a plant-based diet, which is good for the body and good for the planet. Sufficient rest and prayer and meditation. It's true that really does work. Now, this area here on our sheet, you're going to see natural anti-inflammatories. You're going to see appropriate and inappropriate biomechanics. You're going to see traumatically induced scoliosis corrected. You're going to see reverse curves in the neck corrected. There's not many professions that do this. There's 600,000 MDs in America. There's 6,000 or 60,000 chiropractors in America. So that's like a 10-to-1 ratio. There's only about 6,000 corrective chiropractors in America. So you got 1,000 times greater chance, of finding somebody that won't be able to help regenerate a disc than somebody that will. If somebody does a before and after x-ray, you got a sharp guy, or gal. You got somebody that'll be able to correct you. So respect your body. Thank you very much.